Welcome to the deep dive. Today we're tackling optic neuritis. It's a condition that can really throw a curveball at your vision, sort of seemingly out of nowhere. Think of it as a sudden hiccup in that communication line between your eye and your brain.
Exactly. And we've got some really focused revision notes here. Our goal today is basically to pull out the most important info about optic neuritis, help you understand it, and crucially, help you remember the key bits for revision.
Right.
We'll try and use some memory aids too, where we can.
Perfect. It might sound a little complex maybe, but we're going to unpack it, step by step, make sure the really important stuff sticks.
Sounds good.
So let's start right at the beginning then. What exactly is optic neuritis?
Okay, so in simple terms, optic neuritis is inflammation. Inflammation of the optic nerve.
The optic nerve, that's the main cable-carrying vision info to the brain.
That's the one. It's absolutely vital. Carries all the visual information from the eye straight to the brain so we can, well, see. Any disruption there, it's going to have noticeable effects.
Okay, so inflammation of this vital cable. What are the first signs then? What would make someone think, hang on, something's not right here?
Well, the two main things are usually sudden vision loss. It can be quite dramatic and discomfort, maybe even pain around the eye.
Discomfort or pain?
Yeah, and interestingly, that pain often gets worse when you move your eyes.
Ah, okay. Because the nerve's attached, moving the eye pulls on it.
That's the idea. Movement can sort of tug on those inflamed tissues. Makes sense, really.
Sudden vision loss, pain with eye movement.
Yeah.
Definitely sounds like red flags. But what actually causes this inflammation? What sets it off?
Yeah, this is where it gets a bit tricky. Often, the exact trigger, well, it isn't completely clear. But a major suspect is an autoimmune response. Basically, your body's own defense system gets confused.
Right.
It mistakenly identifies the protective coating around the optic nerve fibers, that's called the myelin sheath, thinks it's foreign, and attacks it.
So, like friendly fire, almost. The body attacking itself, targeting a really crucial part of our vision system. And the notes mentioned infections can sometimes kick things off.
That's right. Sometimes, a virus or bacteria can act as a trigger. It somehow sets off that misguided immune reaction we were just talking about.
Okay.
And the notes we have give a pretty good list of specific conditions that have been linked to it.
Let's go through some of those because it really shows how wide-ranging the causes can be. First up is multiple sclerosis, MSRA.
Yes.
That often comes up with nerve issues, doesn't it?
Oh, absolutely. MS is a key one. Think of it as a prime example where that myelin sheath gets targeted not just in the optic nerve, but throughout the central nervous system.
Right. Then we've got things like diabetes and syphilis.
It just shows that other illnesses happening elsewhere in the body, systemic illnesses, can have knock-on effects on the nerves, including the optic nerve.
And then ischemic optic neuropathies,
Yes.
like giant cell arteritis. Ischemic meaning lack of blood flow.
Exactly. So the nerve isn't getting enough oxygen or nutrients. And then there's corticosteroid responsive ON that's interesting because it points to an underlying inflammation that, well, responds to steroids.
Suggests an autoimmune link again, maybe?
Precisely. The list goes on, though. Other general inflammatory conditions, specific infections like TB or Lyme disease, even nutritional things.
Like B12 deficiency.
Yeah, vitamin B12 deficiency, certain drugs or toxins too, like Amiodarone is mentioned, inherited conditions like Leber's hereditary optic neuropathy, and even common viral infections, especially in kids.
Wow, okay. It really covers a lot of ground.
It does. It underlines how diverse the pathways leading to optic nerve inflammation can be.
So with all these potential triggers, who is actually most likely to get optic neuritis? Are there clear risk factors?
Yes, the notes outline the main ones pretty clearly. High up is a history of autoimmune disorders, and MS gets another specific mention there, reinforcing that strong link.
Okay.
And, like we just said, certain viral or bacterial infections can make you more susceptible.
And interestingly, the notes also point to gender.
They do. It seems optic neuritis is diagnosed more often in females.
Huh.
And age is also a factor. It tends to hit young adults most often.
Okay, so female, young adult, maybe a history of autoimmune issues or recent infection. Those are the key groups.
Got it.
So we know what it is, what might cause it, who's at risk. Let's dig into the biology a bit. What's actually happening inside the nerve when someone gets optic neuritis? The pathophysiology.
So the core problem, as we've said, is that inflammation of the optic nerve. This inflammation messes up the normal flow of those visual signals traveling from the eye back to the brain.
Right.
And crucially, the inflammation often damages the myelin sheath, that protective layer we talked about.
And that's the key bit. Damaging the myelin sheath stops the nerve working properly, leading to the vision loss, like Stripping the insulation off a wire, maybe? Making the signal fuzzy or weak?
That's a great analogy. Exactly. The myelin is essential insulation. Damage it, and those electrical signals carrying vision info just can't travel efficiently. And that leads directly to those characteristic visual problems.
Makes sense. Okay, so if someone comes in with these symptoms, vision loss, eye pain, what else might be going on? What other conditions do doctors need to think about before landing on optic neuritis? What's the differential diagnosis?
Yeah, that's really important because the symptoms can overlap. The notes list ischemic optic neuropathy. That's where the nerve suffers from lack of blood supply, kind of like a mini stroke affecting the optic nerve.
Okay, lack of blood flow.
Then there's compressive optic neuropathy. That's where something is physically squashing the nerve. A tumor, maybe, or swelling.
Different mechanisms, but I see how the vision loss could look similar. What else is on the list to rule out?
We also have other inflammatory or infectious conditions that can directly hit the optic nerve. Then posterior scleritis, that's inflammation of the white outer coat of the eye, the sclera at the back, maculopathy.
Affecting the central retina.
Exactly, the part for sharp vision. And retinopathy, which is more general damage to the retinal blood vessels. And finally, they mention big blind spot syndrome.
Big blind spot syndrome.
Yeah, it sounds odd, but it's usually benign. The normal blind spot is just bigger than usual, and sometimes that can mimic other vision field issues.
So a careful check and ruling things out is key. Okay, zooming out a bit, what about the numbers? How common is optic neuritis in the UK? The epidemiology.
The notes give some useful UK figures. The annual incidence, so new cases each year, is around 5 to 8 cases per 100,000 people.
Okay, so not incredibly common, but definitely something doctors will see.
Definitely. And as we mentioned, it mainly affects young adults, and it's more common in women.
Right, got it. Now let's really hone in on what it looks like when someone has it. The clinical presentation. What does the patient actually experience, and what does the doctor see?
Okay, so the notes highlight several classic features. The vision loss usually comes on acutely, suddenly, over hours or maybe a few days.
Okay.
And it's typically unilateral, just one eye.
One eye, usually.
Yeah. And this vision loss tends to get worse over a few days, peaking within about 2 weeks, usually.
And the pain. We mentioned that. Pain with eye movement.
Definitely. That's a big clue. And another hallmark is poor color discrimination, specifically something called red desaturation.
Red desaturation. What does that mean in practice?
It means reds look less red, washed out, maybe duller, maybe even a bit brownish compared to how they look with the healthy eye. Think of a bright red post box looking sort of faded or muddy.
Huh. That's a very specific symptom. Easy to remember. The notes also mention a relative afferent pupillary defect, RAPD. Sounds technical.
It does, but the concept is straightforward. Imagine shining a torch in each eye, watching the pupils. Normally they constrict, right?
Yeah.
With an RAPD, when you swing the light from the good eye to the affected eye, both pupils actually get slightly bigger. They dilate a bit instead of constricting.
So the affected eye isn't seeing the light as well.
Exactly. It shows the affected eye isn't sending as strong a signal back along that optic nerve. It's a key neurological sign, sometimes called a Marcus Gunn pupil.
Okay, Marcus Gunn pupil, got it. And a central scotoma.
Yes, that's a blurry or dark patch right in the middle of your vision. Makes reading or seeing faces difficult. So the notes mention this classic triad, which is really useful for diagnosis. Blurry vision, pain on eye movement, and that impaired color vision, especially the red desaturation.
Blurry vision, painful eye movement, reds look dull, the classic triad.
Yeah.
And while it's usually one eye, it can sometimes be both.
It can, yes, although one eye is much more common for the typical kind. There are other possible symptoms, too. Photopsia, flashes of light.
Flashes.
A Fedoff's phenomenon, that's vision getting temporarily worse when body temperature goes up, like after a hot shower or exercise.
Oh, interesting. That's definitely worth asking about.
For sure. And then there's Pulfrich's phenomenon. That's a weird one where moving objects look like they're swinging in a curve.
Okay, that is weird. So it sounds like the diagnosis relies heavily on the patient's story and the eye exam findings, especially that RAPD sign.
Initially, yes, but then the notes make a really important distinction between typical and atypical features.
Ah, okay.
Recognizing these helps figure out if it's likely to be acute demyelinating optic neuritis ADON, often linked to MS, or if there might be another cause altogether.
Right. Let's break down those typical features first, the ones that fit the classic ADON picture.
Okay, typically we see this in adults, usually under 45, vision reduction in just one eye. The onset is pretty quick, developing over maybe a couple of weeks max. Pain on eye movement is there, but usually not so bad it wakes them up at night.
Okay.
And importantly, people with known MS might get recurrent attacks.
Right. So younger adults, one eye, rapid onset, noticeable but not crippling pain. That's typical ADON. Now, what about the atypical features, the things that make you think, maybe this isn't just ADON?
Right. Atypical features raise the alarm for other causes. Things like the patient being very young, under 12 or older, over 50, or if they are of Black or Asian ethnicity.
Okay.
If vision is affected in both eyes at the same time, that's atypical. If the vision loss keeps getting worse for more than 2 weeks after it started, that's another flag.
And the pain characteristics.
Yeah, if there's no pain at all, that's atypical.
Hmm.
Or conversely, if the pain is really severe, waking them from sleep, stopping them moving their eyes properly, or if the pain starts after the vision loss begins, all atypical.
The timing and severity of pain seem really key differentiators. What else is atypical?
Well, if there's a history suggesting something else is going on, like a known autoimmune disease, a recent serious infection, maybe even cancer. Also, if that RAPD sign we talked about is missing, that's a big clue. It might not be typical ADON.
No, RAPD is a significant finding then.
Definitely. And finally, any unusual findings on the eye exam itself. Significant inflammation inside the eye, a really swollen optic disc that's called papillitis, bleeding around the disc, or a specific pattern on the retina called a macular star. All atypical, all warranting a deeper look.
So spotting typical versus atypical is crucial for guiding what happens next.
Yeah.
Which brings us to investigations. What tests are typically used for optic neuritis here in the UK?
Okay, the notes list several key ones. First, basic visual acuity testing, checking the vision chart. Second, visual field assessment, mapping out their peripheral and central vision. Third, ophthalmoscopy, the doctor looking at the back of the eye at the optic nerve itself.
And you mentioned OCT earlier, optical coherence tomography. How does that fit in?
Yes, OCT. It uses light waves to get really detailed scans of the retina. It can precisely measure the thickness of the nerve fiber layer.
Ah, okay.
This layer often gets thinner in optic neuritis, so OCT gives objective evidence of nerve damage. And then finally, an MRI scan of the brain and the orbits, the eye sockets.
And the MRI is looking for?
It's mainly looking for those demyelinating lesions, those areas of inflammation or scarring in the brain's white matter, which are characteristic signs of MS.
Gotcha. So those are the standard tests. But the notes also say extra tests might be needed depending on what you suspect.
Absolutely. If MS is strongly suspected based on the MRI, they might also do an MRI of the spine to look for lesions there too.
Makes sense.
If giant cell arteritis seems possible, especially in older patients, then blood tests like ESR and CRP, those are inflammation markers, and maybe even a temporal artery biopsy are needed.
Right.
If neuromyelitis optica, NMO, is suspected, there's a specific blood test for NMO IgG antibodies. And for other general inflammatory causes, they might run a panel of autoantibody tests.
But just to circle back for that typical ADON presentation, the diagnosis is mainly clinical, based on the story and exam.
Primarily, yes. But if any of those atypical features pop up, then you need that broader investigation workup to rule other things out. That could mean more blood tests, maybe repeating the antibody tests, a chest x-ray, perhaps CT or MRI scans with contrast dye, sometimes a lumbar puncture to test the spinal fluid, and maybe visual evoked potentials, VEPs.
VEPs, what are they measuring?
They measure the electrical signals in the brain in response to seeing a visual pattern. It basically tests how well the visual pathway is working.
Right. And there was a quick note about MRI and contrast vision testing relating to MS risk.
Yes, that's interesting. We know MRI showing those white matter lesions is a big predictor for developing MS later on, but some research suggests that testing contrast sensitivity, how well someone sees subtle shades of gray, might actually provide similar information about that future MS risk, specifically in optic neuritis patients.
Fascinating. Okay, so we've reached a diagnosis, optic neuritis. What's the usual management approach in the UK? How's it treated?
The main goals are, 1, manage the symptoms, try to reduce that inflammation and help vision recover, and 2, address any underlying cause if one is found. Often, the first line of treatment is high-dose intravenous corticosteroids, usually methylprednisolone.
Intravenous, so given through a drip.
Yes, and that's typically followed by a course of oral steroid tablets, pills, which are slowly reduced, tapered over several weeks.
Why the 5E route first? Why not just start with steroid pills?
Good question. The notes point out that IV methylprednisolone seems to speed up how quickly the vision recovers in the short term.
Ah, speeds things up.
But importantly, it doesn't seem to change the final visual outcome compared to just waiting or placebo. And interestingly, using oral prednisolone alone without the initial high V dose is generally avoided.
For that.
Studies actually suggested it might increase the risk of having another attack of optic neuritis later on.
Oh, right. So IV first, then an oral taper. Avoid oral only. Good to know. And it's important to mention if there is significant long-term vision loss, that's often permanent.
Unfortunately, yes. If the nerve damage is severe, the resulting visual impairment can be irreversible.
Okay. What about treating those underlying causes we talked about?
Right, that's crucial too. If it's giant cell arteritis, high-dose oral steroids are essential to prevent more vision loss. If it's B12 deficiency, well, B12 supplements are the answer.
Simple off.
If it's linked to MS, then disease-modifying drugs, DMDs, come into play to manage the MS itself. The notes list examples like interferon beta, glatiramer acetate, fingolimod, natalizumab, alemtuzumab, lots of options there now.
And for NMO, neuromyelitis optica.
Acute attacks there are usually treated with high-dose IV steroids, similar to optic neuritis, and often plasma exchange plasmapheresis, which helps remove harmful antibodies from the blood.
Okay. And what about non-drug approaches? For managing those weird visual things like Pulfrich's or Uthoff's?
Yes, there are some simple things. For Pulfrich's phenomenon, the curved movement thing, sometimes wearing a tinted lens over the unaffected eye can help cancel out the effect.
Interesting trick.
And for Autoimmune vision worsening with heat, the advice is mainly avoidance. Steer clear of hot environments, maybe have cool drinks, avoid strenuous exercise in the heat, and reassurance is key, letting patients know it's temporary, not further damage.
So a mix of treatments. Hitting the acute inflammation, tackling any root cause, and managing the specific symptoms. What about the long term? What's the prognosis generally like for optic neuritis?
It varies, obviously, depending on the cause and severity. But the good news is that most people, the majority, do experience significant recovery of their vision, often partial, sometimes complete, usually within weeks to months.
That's encouraging.
It is, but we do have to acknowledge that some people will be left with some degree of lasting visual impairment. Blurred vision, maybe issues with color or contrast.
And that link to MS again. The notes stressed the increased risk.
Absolutely. An episode of optic neuritis is a known risk factor for developing MS down the line. And the notes give that statistic if the MRI shows 3 or more typical white matter lesions in the brain. The risk of getting an MS diagnosis within 5 years is about 50%. 50%. So the MRI is really important for that long-term prediction.
That's a really significant number. Definitely highlights the importance of follow-up. So what are the other potential complications of optic neuritis itself?
Well, the main ones mentioned are, firstly, that persistent visual impairment we just talked about.
Yeah.
Secondly, recurrent episodes. Some people get optic neuritis more than once.
Right.
And thirdly, as we've heavily emphasized, the potential development of multiple sclerosis. Because of all this, regular follow-up and monitoring are really important. Keeping an eye on vision, watching for any new symptoms.
Makes perfect sense. Okay, so to quickly recap our deep dive on optic neuritis, it's inflammation of the optic nerve causing sudden vision changes, often pain with eye movement, maybe color issues. We've looked at the potential causes, often autoimmune, sometimes infection-related or linked to things like MS. The risk factors like age, gender, autoimmune history. What's actually happening to the nerve, the mild damage?
Yeah, the pathophysiology. And what else? It could be the differentials.
Right. How common it is, the classic signs like the triad and RAPD, and those crucial typical versus atypical features.
But definitely key for guiding investigation.
Then the investigations themselves, exam, fields, OCT, MRI.
Yeah.
And the management. Steroids, treating underlying causes, symptom support.
And finally, the prognosis, mostly good recovery, but potential for impairment and that significant MS risk.
Exactly. That's a pretty thorough run-through, hopefully giving you a really solid handle on it for revision.
It is, and hopefully breaking it down like this, focusing on those key features, sudden onset, usually one eye, pain on movement, red desaturation helps it stick. And remembering that typical versus atypical distinction is vital.
Absolutely. And for anyone listening who wants to dive even deeper or get more practice questions and revision materials, definitely check out pastthemsra.com and freemsra.com. Really great resources there.
Definitely worth a look. You know, exploring optic neuritis really does underscore that incredibly intricate link between our eyes and our brain, how easily that connection can be disrupted, and how profoundly that affects how we see the world. It's quite something to think about.